Medical School. This is Ashrafur Rahman Tamal. He's a very good student. I knew he was going to shine, and he is really shining. He's one of the top students in his batch. He's from Dhaka Medical College as well, where we were the almost contemporary in the Dhaka Medical College campus. He is currently working as an assistant professor in NICVD, and he is going to talk about mitral stenosis, its assessments, and the structural interventional part. We have three esteemed panelists here. One of is our all-known Dr. Nasser Khan, who is the Director of Structural Program in Methodist Dallas. Thank you for joining. We have Dr. Abdul Momin. I'm not sure Momin bhai joined or not yet. Momin bhai apni ki join korte perechen?
Hey, yes, I am joined as a Bangladesh Specialist Hospital Limited.
Oh, thank you, Momin bhai. Thank you for joining. So Momin bhai is an associate professor of cardiology, and he is in NICVD as well, and he is a structural interventionist doing coronaries, mitral balloon valvuloplasty, and ASDs. And we have Dr. Tawfiq Shahriar Haq. He is also associate professor and senior consultant cardiologist at National Heart Foundation. I have done multiple sessions with him, and I'm really pleased to have him as a panelist here. We have many other esteemed colleagues who joined here, Professor Azam, Dr. Shiraj Monira Lopa. I'm seeing Sadia from UK. I'm seeing Asif from UK. Asif is an aortic, right? Asif, you're aortic surgeons, right? You're specialized is in aortic surgery?
Yeah, this is my subspecialty, but
subspecialty. You are a cardiothoracic surgery, definitely.
Yeah,
but your specialization is aortic surgery. And thank you for joining. And we will start. Who wants to go first? Who wants to start here? Want to do mitral stenosis?
I can start first if you want.
Okay, sure. So I would like to invite Dr. Islam to start his presentation, and thank you for joining and teaching us today about the mitral valve.
Not sure about teaching, but I will share my 2 cents about this. Make sure that, can you see my slides now or no?
We can. Yeah, we do see your slides.
Okay, good. Let's see, 1 second. Okay, thank you kindly for inviting me for this session. Of course, this is a great, achievement from Nashrafi, Tasbir, and Nasser, and all of you who actually have made this happen for worldwide audience from Bangladesh. So I think it's a great thing to have, especially in a nonprofit organization status, trying to educate and train people with Bangladesh background. And thank you for inviting me. So, I'm not going to, get into too much into the technical aspect of things without knowing, if that will be really helpful at all. But just to kind of shed lights on what we do in our practice for mitral valve disease. The mitral regurgitation is definitely one of the commonest valve disorders in US and in Western world in elderly people. And often it is associated with congestive heart failure, whether it is the primary pathology, which is primary mitral valve disease, or secondary pathology, or secondary MR related to LV dysfunction from ischemic as well as non-ischemic cardiomyopathy. So untreated MR in heart failure is a very significant disease with high mortality and morbidity. As you can see, 1 year mortality in this population could be more than 50%. And 30-day hospitalization rate is anywhere between 25 to 50%. So it's a significant economic load for healthcare in the US and other Western countries. As I said, it is common and increases with age. MR is the most common type of heart valve insufficiency in the United States. As you can see, the incidence increases with age. For aortic valve disease, which is what we are treating mostly now, but mitral valve definitely is a commoner valve pathology in elderly population. So I think the future development in technology and as well as surgery will really have to address this increasing need of patients with MR. In heart failure patient, as I said before, there is significant lower survival rates according to the degree of MR. This has been shown over and over again in ischemic as well as non-ischemic MR. Anywhere between moderate to severe MR has significant risk of mortality at 5 years, almost 50%. So even with mild to moderate MR, although it is not highly significant compared to no MR, there is significant decrease in survival over time. As mentioned before, MR really determines, moderate to severe MR also determines repeat hospitalizations. It increases by that more than 80% over 5 to 7 year follow-up in heart failure patients. And the economic burden is huge. In the United States alone, about $40 billion annual cost of heart failure population. And the majority of this cost comes from hospital-based care, probably 60% or more. It's interesting to see that this study actually published in Euro Heart Journal, about 400 patients with severe symptomatic MR and New York Heart Class 3 or more heart failure symptoms. Almost half of them were not even felt to be candidate for mitral valve repair or replacement surgery. And that is mostly due to age or other comorbidities. We see the similar distribution in patients with severe aortic stenosis in the United States. So only 50% receives some consideration, but only 10% receive surgery. And remainder of these patients, they just get untreated or just minimally treated with medications. If you look at the SCCHA updated guidelines, so this is for primary MR. Of course, we all know that primary MR, the best therapy is surgery. Primary MR is degenerative mitral valve disease included. So a patient has significant symptoms, definitely they should be considered for surgery, regardless of LV function. So it doesn't matter LV function less or more. If they have primary severe significant MR and they're symptomatic, they should be considered for mitral valve surgery. So now mitral valve surgery repair is always better than replacement for degenerative mitral valve disease as well as for rheumatic. We don't see rheumatic disease much here in the United States, of course. But some of these patients are going to be high risk or prohibitive risk for surgery. And this is the subset of patients for primary mitral valve regurgitation. And if their life expectancy is more than 1 year, in US, we consider transcatheter ace-to-ace mitral valve repair. The only approved device in this is mitral clip. So this is the patient population we are treating right now in the United States. High risk for surgery or prohibitive risk for surgery. Those are determined by heart team, by STS criteria, and after having a heart team evaluation. For secondary MR, patients who has MR due to LV disease, myocardial disease, whether it is ischemic or non-ischemic. So the first line of therapy is guideline-directed medical therapy. They should be seen by heart failure specialist. This is the recent guidelines. They're suggesting that. But again, as opposed to the primary MR, this is completely different disease. This is a disease of the LV and not the mitral valve itself. So depending on if they have severe MR, which is defined as regurgitant volume of more than 60 ml, regurgitant fraction of 50 or more %, and ERO 0.4 centimeter square or more, they are considered as severe MR. So if they have normal LV function, you could consider mitral valve surgery. So often these patients present with reduced LV function, as you know. In those patients, surgery has no role. And sometimes the surgeons have hard time accepting that, but we remind them there is no data showing that surgery is going to improve their outcomes at all in this secondary MR patients if they have developed LV dysfunction and dilatation already. So in those patients, mitral valve therapy is mainly guideline-directed neurohormonal therapy, optimization over time, CRT, cardiac resynchronization therapy can be considered, of course. And if they are still symptomatic and has more than moderate MR, this is the subset of patients we are treating with mitral clip. There has to have febrile anatomy, LV dysfunction, end-diastolic dimension of 7 or less, and pulmonary arterial systolic pressure of 70 millimeter mercury or less. Why is that? This directly came from a co-op trial, which is a phenomenal randomized control trial in secondary MR patients, comparing medical therapy versus medical therapy plus mitral clip. In those patients, they have significant benefit in survival as well as rehospitalization and every secondary endpoint that investigators looked at. And the benefit sustained over 3 years. So co-op trial literally changed the guideline. So now ace-to-ace mitral valve repair, which is a fancy name for mitral clip, because mitral clip is a trade name, so we don't use that. In literature, it is transcatheter ace-to-ace mitral valve repair, as you all know. So that's the indication for mitral clip in secondary MR. Patients who are already on guideline-directed medical therapy and still symptomatic. I know we have a cardiac surgeon in the panel. So this started, the whole concept of mitral clip actually originated from the surgical procedure Alfieri stitch. Even these days, some surgeons still use this technique to approach the anterior and posterior mitral leaflets to reduce, mitral annular dimensions, mitral orifice area. So of course, annuloplasty ring is very common for mitral valve repair by cardiac surgery, but Alfieri's technique studied the whole concept of mitral clip, which is a transcatheter technique. So this is a co-op trial. It was presented very highly awaited and trial in TCT in 2019 by Greg Stone. As you can see, more than 300 patients in each arm, patients who are with functional MR. This is a parallel control, open label, multi-center randomized control trial. Patients with more than 2+ MR, 3+ or 4+. And they were randomized between guideline-directed medical therapy only, because at that time there was no other treatment, versus medical therapy plus mitral clip. And the primary effectiveness endpoint, efficacy endpoint was hospitalization from heart failure. Significant reduction of that outcome. Patients who are followed in 2 years. 40% versus 68%. The hazard ratio of almost 50% reduction. The primary safety endpoint, device-related complications at 12 months, was of almost 97%. Again, that was a safety endpoint. And all-cause mortality was significantly reduced from about 29% versus 46% in medical therapy arm. So the landmark trial concluded that transcatheter mitral valve repair with mitral clip on a background of, this is most important line, I think, on a background of maximally treated medical therapy was superior. These patients were highly treated, significantly treated with medications before they were enrolled, as opposed to MITRA FR trial, which was done in Europe. It was not a very well done study and showed no benefit with mitral clip. So if somebody tells me that we should not be doing mitral clip because MITRA FR trial actually showed no benefit, they are not really talking neutrally. They're not really talking objectively. That trial was a very poorly done trial. And the severity of MR was not as significant as this trial. You cannot treat secondary MR only with a device. It does not work. We have done that before with cardiac surgery. It failed. So we should not be doing that with transcatheter therapy either. So it has to be done under the background of guideline-directed medical therapy. What does that mean? If you look at ACC/AHA guideline, that includes beta blocker, ACE inhibitor, ARB, Entresto, Aldactone, all those drugs, whenever tolerated, at least for 3 to 6 months, as well as if left bundle-ish QRS complex present and patient still has heart failure symptoms, they should be considered for CRT. And that's exactly what the co-op trial did. Very well-intentioned medical therapy as well as CRT before undergoing or randomizing even between mitral clip and the medications. So in those patients, significantly reduced the hospitalization and mortality. So that's just a Kaplan-Meier presentation of the same concept. You see number needed to treat to reduce all hospitalizations in this trial was only 3. This is pretty remarkable. You don't see this kind of huge effect of any treatment in heart failure patients these days. Number needed to treat is only 3. Much better than, in this regard, even TAVR. So it's a bulky device. It's a complicated device. I still don't feel that I have a good grasp of everything that I am doing in the cath lab with this device. You need at least 50 or 75 procedures in a pretty good frequency. You have to do it, at least 2 to 4 cases a month to be really comfortable with mitral clip. And it has been shown that your timing of the procedure, duration of the procedure, and your ease of doing it and the related complications and whatnot would reduce over time if you have a reasonable volume. So I think, in my opinion, a good volume means you have to do about 30 to 50 cases a year. I mean, the procedure is actually, anybody has any questions so far? Or should I continue?
Let me see if there's any questions in the chat box.
Okay.
I think you just continue for now. Okay. And maybe we'll just open for discussion at the end.
Okay. So, as you all know, this is highly sophisticated and advanced procedure for a very complicated valve. TAVR is relatively easier than mitral clip repair of mitral valve because mitral valve is a complex valve. I have heard this from a very wise man that mitral valve is like a woman and aortic valve is like a man. You see what you get from aortic valve. Mitral valve is very complex. No offense to women who are here, but that's sort of like a funny way of looking at mitral valve. They're very complex. You have to understand the anatomy. You have to understand the pathology to be able to do a meaningful repair, whether you're doing it surgically or by transcatheter technique. Fluoroscopy definitely is part of the procedure, but of course we have to do it under TE guidance. And 3D has really revolutionized the procedure, safety and technical success of the procedure. So I don't know if some of you are involved in structural heart TEE. In US, this is a very rapidly evolving field. We expect structural heart is going to keep growing. And in fact, depending on who you believe, next 5 years or 10 years, the growth could be anywhere between 50% to even 99%. So no matter what, I think a structural heart, especially TAVR and mitral clip and other valve repair and replacements are following suit. They would be a big part of what we do in US and other Western countries. And the load is going to increase. With the same token, structural heart imaging has become a hugely sophisticated and growing field in US. And I congratulate, I think I forgot your name, starting a imaging fellowship at MGH. I had the opportunity to get trained there for a year in peripheral and structural heart. I think I still remember those days. It's a great place to get trained, and I think you'll get the experience and expertise that very few people will have at the end of your fellowship. I still have good friends over there. I work together with them often, share ideas with the structural heart interventionist there. Dr. Pasari is the echocardiographer who is actually involved in structural heart at MGH. A good friend. I think he's one of the best echocardiographers that I have met in a structural heart. In any case, For mitral clip procedure, you need expertise from your echo colleagues. Not everybody can do this effectively and efficiently. We have to have same sort of language during the procedure. One of my colleagues at Bay State often does it with us. There are two other colleagues who are also trained, but definitely not everybody can do mitral clip TEEs. So I'm not an echocardiographer, so I would not pretend to be very good at it. I actually have not done a TE since I have done my fellowship. But I had to relearn myself what I'm looking at and what my colleague is telling me and what I'm telling them to show me, because of the mitral clip procedures. I had to relearn myself again. So the most important views that we use during the procedure, of course, the quantitative and qualitative assessment of MR is almost always done before procedure day. A dedicated TE almost often we do before any patient can be taken to mitral valve procedure. So the most important aspects of imaging is morphological determination. What is the pathology, primary pathology of the mitral valve that is causing MR? Is it primary MR or secondary MR? Is it primary mitral valve disease or it is myocardial disease? So of course, we have both indications in US now, functional MR as well as secondary MR, functional MR being only high-risk patients. So in any case, of course, most commonly you obtain the 0-degree angle, 4-chamber or 5-chamber view, depending upon where you are in the mid-esophageal plane. If you are in the high segment, you will often see the 5-chamber view, and you will see the lateral aspect of anterior and posterior mitral leaflet. If you think about a fish mouth, the medial aspect of that fish mouth of mitral valve is A3P3. The mid segment is A2P2, and the lateral segment is A1P1. So to start off in 0-degree angle, 5-chamber or 4-chamber view, you start evaluating the valve with or without color. The superior aspect will have the lateral aspect of the valve. That means A1 and A2P2. The central aspect, which is you will obtain by advancing the probe in the mid-esophageal, advance the probe 1 to 3 centimeter, you will have LV cavity more completely visualized in this view in the central segment of the valve. The central segment of the valve is A2P2, which is a sweet spot if it is a functional MR or secondary MR. Usually they're leaflet tethering, usually the jet is central. It could be broad, of course, depending on how big its LV is. So the central segment of the mitral valve is A2 and P2. And the inferior segment, if you push down the probe even further, you'll see the medial aspect of the valve in 0 angle, which is A3 and P3. So sort of like scanning this, and then you go to anywhere between 60 to 90 degree, very, very important angle to assess the valve in bicommissural view. So depending on, if you think about the fish mouth of the mitral valve, if you're right in the middle, that would be the midline. If you're to the anterior aspect of the mitral valve, which is obtained by just looking at the anteriorly, which is probably rotating the probe to see the anterior leaflet only, in that view, you're gonna see A1, A2, and P2. Sorry, A1, A2, and A3 scallops. That means in bicommissural view, 60 to 90 degree bicommissural view, very important angle. The T anteriorly will see only anterior leaflets, 3 scallops of anterior leaflets. The posteriorly, it will see only 3 scallops of the posterior leaflet. And in the midline, you're going to see A2 in the middle, but P1 and P3 on the sides. This is one of my most favorite angles to start determining what is exactly going on, because in most common defects, if there is a P2 prolapse or a functional MR, as I said, you will see the jet right here at the A2 level. So in the bicommissural view, it's very important to see that. So A2 would be A1 would, sorry, pardon me. P1 would be the lateral, which is towards the left atrial appendage. And P3 would be towards the septum, which is the medial aspect of the posterior leaflet. And right in the middle, you will see the A2. So the bicommissural view is very important. You have to scan it from anterior to mid to posterior aspect of the valve. What we usually do, we put an X-plane, which is, that means the advanced TE probe has X-planes to put the angle right angle to each other. So when you're at the midline, you could put the right angle of the midline, you will get something like this. You will get the aortic valve as well as A2, P2 together. So if you put one X-plane right at the right angle here, you're gonna get something like this. And the beautiful thing is you'll be able to assess both at the midline, 60 to 90 degrees plus somewhere like this in the long axis view, which is often called LVOT view, because that's exactly looks like transthoracic echo, LVOT, that you obtain the mitral valve and the aortic valve both visualized. And in that segment, just behind the aortic valve is the A2, and posteriorly you have the P2. So with the same token, when you are in the 110 to 130 view, if you're on the lateral aspect of the valve, again, lateral aspect is A1 and P1. Medial central aspect would be A2 and P2. And the medial aspect of the valve, you're going to see A3 and P3 scallop. So these are the basic T angles and concepts to understand, to practice in every single case. So we have a routine, sort of like a protocol that my colleagues would start to evaluate the mitral valve and complete the evaluation by looking at each and every aspect of what we just discussed. It's kind of the repetition of the same concept. When you are doing the X-plane, you can see the valve in 2 different angles to keep not changing from one to the other angle. You can see both angles and both color Doppler studies on the same screen. So if you're in the LVOT angle, you're gonna see the bicommissural view as well as the LVOT angle in the A2P2. This is, if the valve pathology is mostly in the A2P2, you're gonna see the jet in both angles. And then you scan it. If you're in the bicommissural view, you put the line right at that color Doppler where the MR is. You try to go and medial, you try to go lateral, you try to assess the whole valve where the pathology is most. That's how we determine whether I have to go to the lateral aspect of the P2 to start off, or the medial aspect of the P2, or the central P2, depending on where you see the primary jet is. So that's how I start analyzing the valve and sort of strategize where to start. There are a few other things you have to consider. Not all valve pathologies are easy to do, depending on, we have two different length of mitral clip these days. Mitral clip started with NT device, which is the only device available for Quabtral. And then they came up with XT device, which is a wide and long device. So you have two different types of mitral clip. One is the narrow, which is N. One is the wide, which is, sorry, N is the shorter shoulder. The length of the clips is smaller than the XT, which is a longer clip. And you have also two different width now, the narrow width and the wide width. It could be NTW or XTW, which is wide. So the advantage of these new ones are you could put a long XTW that would be longer clip and wider clip. So if you have a very large flail width, you may actually want to do a long and wide clip to begin with, as long as your mitral valve area is adequate. Obviously, otherwise you're not going to get a good result. So I would tend to use that in most of this wide flail gap. And flail gap, of course, 1 centimeter is a very wide jet you would think about. Anything less than 1 is not as wide. You could start with NT, but depending on your choice. The other thing I forgot to mention for assessment of mitral regurgitation, for candidacy for clip, we always do the mitral valve area by 3D, as well as you have to do gradients, the baseline gradients of the mitral valve. So you know where you start with, and then you basically make sure that you have repaired the valve, decreased the MR, and not ended up with significant mitral stenosis either. Some of the degenerative valve disease patients with MAC and thickened leaflets, they may have prolapsed or failed leaflet, but they may have very small mitral valve area, may not be good candidate for mitral clip. In those patients, the options could be very limited, as you know. Degenerative MR with calcification and severe MAC could be very clinically challenging subset of patients. So you measure the gap. Flail gap, you can measure it in the LVOT angle, A2, P2. In this example, you're seeing that P2 is prolapsing back in the left atrium. So you measure the gap there. The flail width, usually best measured in the transgastric view, short axis, or bicommissural, whatever you want to call it. In that view, you can measure the flail gap, flail width. We also would measure the posterior leaflet length. Anterior leaflet is often very long. You don't have to worry about it. But definitely sometimes the long clip may not be a good idea, because if the clip length is less than 7 or even 9, I would prefer to put an NT. Because what you don't want to do, you don't have enough posterior leaflet to grasp, and you put a long clip, you may have single leaflet detachment, because now you don't have grasp length to even put a long clip. So you have to have a very decent grasp with NT 7 millimeter or so length needs to be grasped. With the long clip, at least I would say 9 millimeter or so needs to be grasped. There are some borderline cases we have done, but we have to be very careful not to have subsequent complications. For secondary MR, as you can imagine, there is a significant dilatation of mitral annulus. because of LV dysfunction. And you have tethering of anterior and posterior mitral leaflets. And there is a central coaptation length, which you have to measure. So the central coaptation length is important to measure in 4-chamber view. That's the length you think you will be able to grasp when you put the mitral clip. And if that length is very short, sometimes you can get into trouble too. So if it is a very wide MR, secondary MR, sometimes we may have to come from the side, sort of like a zipping method, I call it, to put two clips or so. So you kind of start from where the coaptation length is adequate for leaflet grasping, and then you tend to come towards the center. But ideally, it would be most beneficial or effective, I should say, to be able to grasp right in the center of the valve, which is A2 and P2 for functional MR. The post-procedure impact of mitral valve repair. It's a very satisfying procedure, at least from cardiologist standpoint or interventional cardiologist standpoint. Often we are seeing these patients very sick. They have no other options. They have declared by surgeon as very high risk, or they have severe LV dysfunction. They're suffering from significant symptoms even after optimization of medical therapy. We have done few mitral clip patients following TAVR. MR was significant enough even before TAVR. After TAVR, it did not improve. The afterload was reduced. Still, MR has become very symptomatic in these patients. And I have done few where we did TAVR followed by mitral clip. Mashrafi and his group, they're academically oriented, very high-end group at Springfield. And I had the pleasure and opportunity to work with each of them. And many of my patients come from his practice as well as my own group. So it's a lot of fun to work together, to form a multidisciplinary team, have patient discussions the way we do it, just like TAVR. If there is a patient transferred by Mashrafi to me, I will see the patient in my clinic separately from the cardiac surgeon. I will look at the TE. I will assess the functional versus secondary MR etiology, whether they have been well treated or not. Sometimes I will include our heart failure specialist to see these patients later on and try to optimize their medical therapy before we decide whether we should do mitral clip or not. Other than functional MR, all the degenerative MR patients will be seen by cardiac surgery. They will consult and declare these patients very high risk or inoperable. Sometimes I would get patients referred directly from them because they don't want to do surgery on these patients. And we would have, depending on how busy we are, sometimes every 2 weeks or so, we have mitral clip patients or any mitral valve disease patient presented in the multidisciplinary group. We do it virtually. We have program coordinators. They collect the data and imaging studies, and we as a group discuss over Zoom anatomy and everything else. And then we decide whether we should do this patient or not. In that meeting, we invite heart failure, interventional cardiologists, and sometimes even primary cardiologists who know these patients more than we do, as well as our advanced echocardiographers. So I think the most fun I have as interventional cardiologist is this, when we actually discuss patients and then decide and go for the ultimate procedure, what is best for the patient and not best for us. It's a very rewarding experience for me. So structural heart intervention has really changed my life. And and hope you will experience that in your own career if you desire to do this procedures in the future. So in any case, the length of a stay is usually not bad. They're always optimized even before they come for mitral clip. Of course, there is still very symptomatic. Usually the length of a stay is less than 3 days. Majority of the patients are actually discharged home in this study. And this is the same experience we have. A majority of our patients, they go home. If the patient's quality of life is so impaired and their longevity is really impaired, less than 1 year, you probably should not be doing this case. These are historical evidence of different medical centers, how they benefited from having mitral clip program. Just like TAVR program increases referral to cardiac surgery overall, mitral clip also does the same. You see the mitral clip procedure as University of Virginia experience, as it increases the number of mitral clip procedures over, obviously these are all slides, they also saw anywhere between 70 to 80% increase in isolated surgical mitral valve cases. So it's sort of like, you're raising the volume for both cardiac surgeons and yourself. Same with Germany. Mitral clip procedure, as they increase the volume, they also saw volume increase in other non-mitral clip related mitral valve procedures, which is of course mitral surgery as well. Long-term cost saving, at least, in US experience is significant. There is a 73% reduction in heart failure hospitalization rate in this study. And average hospitalization rate per patient was decreased from 67% to 18% in 1 year. So that is a cost saving of more than $1,600 per hospital admission avoided. So the cost saving for the hospital could be quite significant for long-term cost saving after mitral clip. Why is it? Why mitral clip good for patients, or why is it important? It serves as an important group of patients for which there is no good alternatives. It is minimally invasive, by the way. It's not a high-risk procedure. It sounds high risk because it's a complex valve, but it's less riskier, in my opinion, than doing TAVRs. It definitely has huge implication in improving quality of life and survival in highly selected patients, adequately selected patients. Believe it or not, it is the most common Google search word in mitral valve territory, mitral clip in US. Something happened here. Okay, sorry. I'm almost done here, so I'm not even sure how long I've been talking. So the functional improvement in mitral after mitral valve is also significant. If your patients are highly significant, that means class 3 or class 4, post-mitral clip follow-up, this is similar experience that we have in our center and US database is at 1 year post-mitral clip, only from 87% to 13% only will have class 3 or class 4 heart failure symptoms. So the quality of life improvement is significant. As you can see, after 1 year, the success rate is quite reasonable, in my opinion. We don't see a whole lot of failure. But if the mitral clip fails, usually it fails within first 6 to 12 months. If there is a durable result after 6 to 12 months, usually these patients do well over long term. At least that's what my personal experience has been. If you don't mind, I'm going to get my computer on the other side. I have to put the power cord. This is probably my last slide anyway.
I just have a quick question, and for all the participants who are here from Bangladesh.
Yes.
for Bangladeshi participants, I know this is a procedure which is sort of like a little new things. Is there any questions that you guys think about how we can help to transfer this sort of technologies back home if anyone is interested to do this sort of cases? What sort of logistic supports do you guys think needed in Bangladesh?
Actually, there is no set mitral program in any hospitals till now in Bangladesh. We have taken at our hospital. We have taken up this plan, and we hope to start this, and we have a first training session on the 2nd or 3rd week of August. So again, just like TAVR, what's happening is, as I can assume, the price is going to become an issue, as you know, we don't have insurance coverage for it. So, but still, one or two TAVRs are being done here and there in our country now. So hopefully it will pick up soon. And just like that, we also think mitral TP is also going to pick up. So once we get trained in that, hopefully then we can again get back to you and see how can you help us here, because it's a totally new thing for our country. None of the hospitals have done it, or no one has a set program for that.
Right. So right now the TAVR is self-pay, right? Of course.
In Bangladesh, it's all out-of-pocket payment. So
yeah.
Maybe in the whole country till now, if around 6 to 8 TAVR has been done. Right, Momen, if I'm not wrong?
Mm-hmm.
Yes, only 7 TAVR have been done so far.
Okay.
5 in ICVD and 1 in 2 other in 2 private hospital. Same thing, but TAVR, one thing is that there is Indian TAVR, which is less costly. So 50% price from the US product. So it is a bit cheaper, and Indian population expert comes here, and we in ICVD we have 5 experienced, Dr. Pradeep Kumar Karmakar and his team. I also a member of this team, and we did 5 TAVR. We did in all our Indian valves. These are the Mitral valves. So, but there is
this
no
self-expanding valve.
Yes.
Sorry, or balloon expandable.
Self-expandable.
Okay.
But there is no alternative option in mitral clip. So we have to purchase the mitral clip, which is a bit costlier, and the patients are in the debilitated condition. Mostly, many of the families they thought that there is a few life expectancy, why we should go. So for that reason, it is not popularized, but we have the plan. I have few patients already, and we are contacting a few experts, and one patient is already a bit advanced to do it. So if we can prepare, and then if he is all right and everything is going fine, then we can take help from the expert like you.
Like we lost your, okay, we got it back.
Thank you so much. Thank you,
Can I ask a question? Sorry.
Sure, of course.
Sure. Yeah.
Yeah, so I'm a cardiothoracic radiologist at the Papworth Hospital in Cambridge. Just to introduce myself, I was just wondering, TAVR in Bangladesh, how do you plan? Do you have a radiologist planning the TAVR, or the cardiologist? How do you measure the valve, or the planning part, how it is done?
Actually, it is done in Merrill Academy, India. They have all the facilities because they supply the valves. We got the CT angiography of the patient, send them to the CT angiography to that team. They assess. With the Zoom meeting, a conversation is there, and then plan the size and other things.
Okay.
So
sure.
we have no definite complete protocol in Bangladesh. Because our radiologist is not so far trained how to measure everything. So it should be a dedicated program. Will more comfortable with a dedicated program.
Okay, yeah, that's all right. And if you need any technical help or anything, I'm very happy to help because
okay, thank you.
I do it almost every day, so it's part of my job. So thank you.
Thank you, Sadia. Thanks for offering this help, definitely. And I think for the purpose of time, we'll proceed with Ashraf Rahman Tamal's presentation, please.
Yes, Dr. Mashrif, I'm ready. I think I should share the screen.
Sure, thank you.
Am I visible? Is my screen visible, Mashrif?
Yes, yes.
So I'm Dr. Ashraf Rahman Tamal. Thank you, Dr. Mashrif Bhai, my dear elder brother, for inviting me to present in this Sanitary Health Academia webinar. And I will talk on the mitral valve stenosis, its assessment, and some structural intervention, and our experiences here in Bangladesh. I'll go first to the very basic. A 37 years old housewife, mother of two healthy baby, non-autistic, non-diabetic. She presented with breathlessness and pulse for 6 months. And as we know, the basics of MS, there is a visible apical impulse, epic beat in the left hip interosseous space, and it's tapping the diastolic field, palpable P2 left distal hip, and epigastric pulsation. And on auscultation, these are classical findings of MS: loud faster sound, and loud P2, and a mid-diastolic murmur, which is low-pitched localized sharp rumbling, as you all know. And there should be an opening sign. So these are the basics of MS, and on the basis of MS, we do the ECG, and we look forward to the P mitrally and evidence of LA enlargement. And mitral valve area is 4 to 6 centimeters square, as you all know, but symptoms don't occur usually unless it is less than 1.55 centimeters square. And rheumatic MS is very common in our part of the world. In Bangladesh and in India, we face a lot of cases of MS, and mostly those are the rheumatic origin. But there are some other causes of MS, like degenerative, some congenital MS, subvalvular abnormalities, some SLE cases, and some carcinoid heart disease. But mostly we deal cases of rheumatic MS. The ACC AHA guideline in 2014, they stage the MS as at risk of MS and progressive MS. At risk of MS, they don't have any transmitral flow velocity. And progressive MS, the valve area is more than 1.5 centimeters square, and pressure half time is less than 150. But there are some rheumatic changes in the progressive MS. And this is the asymptomatic severe MS. They call it stage C. Here you can see the valve area is less than 1.5 centimeters square, and very severe, they call it less than 1 centimeter square. We get a very lot of patients in this group, some severe MS who are asymptomatic. And when these MS patients are symptomatic, they call it stage D, the symptomatic severe MS. The valve area is less than 1.5 centimeters square. And here you can see there is severe LA enlargement and also raised PSP more than 30. So these are the treatment groups which we offer some structural intervention. How will we evaluate in the echo? You can see in the flex view the valve is thickened. There is diastolic probing of the AML, and there is enlarged LA. And this is the mitral valve area on the short axis view. Here you can see the valve area is 0.9 centimeters square. This is severe MS. This is the fish mouth appearance of the mitral valve area. This apical fourth chamber view, you can see the valve is thickened, calcified, there is enlarged LA with restricted opening. And these other 2D features are dilated LA and LA appendage thrombus, paradoxical septal motion, dilated RV and RA. So we have to assess the MS severity by the M mode, by 2D echo, and by Doppler. In M mode, if we look carefully, in the normal mitral valve, there is an E wave and an F wave and A wave. But in case of MS, there is anterior motion of the posterior leaflet in diastole. Here you can see that the posterior leaflet is anteriorly placed in diastole, and there is decreased rate of diastolic closing of AML. That means decreased EF slope. The EF slope is flattened here. So this is the normal mitral valve. There is EF slope, and in MS patient, the M mode shows there is flattened EF slope. So this is some guide in the M mode that patients has mitral stenosis. So we'll quantify the MS severity by mean gradient by doing an VTI. If it is more than 10 millimeter, then we call it severe MS. We have to look for the mean gradient. And we also measure the pressure half time. If it is more than 220, it is severe. And if its pressure half time is less than 220, we have to consider other methods to assess the severity. But the pressure half time methods is unreliable immediately post balloon mitral valvuloplasty or after PTMC, as it might underestimate the mitral valve area. We also have to look for configuration of the left atrial enlargement, associated MR, severity of AS. Severity of AS may be underestimated in case of MS. And if there is presence of AR, the pressure half time method is not a valid method to assess MS. We have to keep in mind, and we have to assess the secondary pulmonary hypertension by the TRZ in patients with MS. And 3D echo has higher accuracy than 2D echo. And we can get detailed information about the commissural fission and subvalvular involvement. And mitral valve area measurement in calcified and irregular valve can be possible in case of 3D. So after diagnostic MS in echo, we do the Wilkins score by 4 categories: mobility, thickening, caudal involvement, and calcification. And we get a score of 4 to 16. And if the score is more than 8, it is the unfavorable valve morphology for proceeding for PTMC. If the score is less than 8, then it is safer to proceed for PTMC. And limitation of Wilkins score is commissural involvement is not included here, and limited inability to differentiate nodular fibrosis from calcification, and doesn't account for uneven distribution of pathologic abnormalities, and frequently underestimation of subvalvular disease. But for MS patient, if Wilkins score is 8 to 10, these patients, these are in the gray zone patients. They can be also considered for PTMC. But if less than 8, then it is safer to proceed for PTMC. And it is said that if it is more than 10, then PTMC is mostly contraindicated. And these are the other PTMC echo scores like commissural calcium score, cornea score, real-time 3D echocardiography score, Chen et al. Score, Reid score, Nobuyoshi score. So these are some clips of the color flow across the mitral valves. You can see that turbulent flow with enlarged LA. And this is a patient with AF. So there is variation in the transmitral gradient. So we have to take three flow and take the mean gradient and doing an average of them. Then if we get the average more than 10, then you can say it's severe MS. This is the transthoracic view showing the LA appendage is free from thrombus, and this is the T view showing the LA appendage. There is spontaneous echo contrast, but LA appendage is free of thrombus. So before the PTMC procedure, we have to proceed for TE to see the LA appendage, and we have to measure the PSP also by the TRZ. And this is a clip. Sorry. this is a clip showing some thrombus in the LA, and this is another clip of a rounded thrombus in LA, and LA is usually enlarged. You can see. So MS often causes thrombus in the LA, and sometimes these are easily visible in the transthoracic echo also. This is spontaneous echo contrast in the LA, and you can see RARB is quite dilated. And this is a hugely enlarged LA. You can see the LA size is 99 millimeter. And here it is 79 millimeters. So hugely enlarged LA with pulse at the septum is possible in case of rheumatic MS, severe MS. So what are the recommendations of treatment of MS? 2021 ESC guideline recommends percutaneous mitral commissurotomy or PTMC is recommended in symptomatic patients without unfavorable characteristics of PMC. And PMC is also recommended in any symptomatic patients with a contraindication or a high risk for surgery. And mitral valve surgery is recommended in symptomatic patients who are not suitable for PMC in the absence of futility. And PMC should be considered as an initial treatment in symptomatic patients with suboptimal anatomy, but no favorable clinical characteristics for percutaneous mitral commissurotomy. This is class 2A indication. And PMC should still be considered in asymptomatic patients without unfavorable clinical and anatomic characteristics for PMC in those who have high thromboembolic risk, on those who are high risk for hemodynamic decompression, like very high systolic pulmonary pressure at rest or need for major non-cardiac surgery and desire for pregnancy. In these group of patients, PTMC is a class 2A indication. So these are the contraindications we have to keep in mind in case of doing PTMC. Mitral valve area more than 1.5 LA thrombus, more than mild MR. We have to assess the MRZ very carefully. If the MR is more than mild, PTMC should not be done. And also severe or bicommissural calcification. The Wilkins score doesn't include this commissural calcification. So if a patient has bicommissural calcification, he is not a candidate for PTMC. And also severe concomitant aortic valve disease or severe combined tricuspid stenosis or regurgitation requiring surgery, these patients should proceed for surgical NVR. And this is the ASC guideline showing that valve area less than 1.5 and patient with symptoms. And if there is no contraindication for PMC, these patients should proceed for PMC. And if there is contraindication for PMC, these patients should proceed for surgery, that means MVR. And if the patient is symptomatically okay, but there is high risk for embolism, and there is exercise testing, there is symptoms, and there is contraindication to or unfavorable characteristics for PMC, then they should proceed for surgery. If there is no contraindication or unfavorable characteristics for PMC, they should proceed for PMC. This is class 2A indication, class 2A. And these are the unfavorable characteristics for PMC. That's the echographic that Wilkins score more than 8, or cornea score 3, very small mitral valve area, and severe TR. And these are the unfavorable clinical characteristics. That means old age, history of previous commissurotomy, NIHA class 4, permanent AF, and severe pulmonary hypertension. In case of AF, in case of valvular heart disease, you can see NOACs are recommended in preference to vitamin K antagonists in patients with aortic stenosis and aortic and mitral ligation. But in case of MS, we can only use the vitamin K antagonist, not the NOAC. NOACs are class 3 indication here. So in case of moderate to severe MS, we can use only warfarin if the patient has AF. Most of our patients of severe MS, they have at least paroxysmal AF or permanent AF. So we have to use this vitamin K antagonist, warfarin, and we have to do the PTI regularly, which is sometimes difficult for the for the population here in Bangladesh who lives in rural areas and has to do their PTI regularly. Now that after selecting the patients for PTMC, we have to prepare the patients by overnight fasting and doing an TE on the day of the procedure and some pre-medication. This is the Inouye balloon with the auxiliary instrument. We do the PTMC by standard Inouye technique. And we take a arterial access and the venous access. This is the 7 to 8 pence venous sheet, and putting an pigtail catheter into the root of the aorta and measuring the aortic pressure. This is the Inouye balloon. We have to debubble the Inouye balloon by a syringe filled with diluted contrast, and it's inflated and deflated at a basin of water. So there is no air bubble is left in the Inouye balloon. And we have to measure the balloon diameter according to patient's height in centimeter. Say if her height is 165 centimeter, we divide it by 10 and we plus it to 10. So it comes to the size of 26 millimeter. This is the sizing of Inouye balloon according to patient's height. So patient's height is 1.4 to 1.6 meter. Then the size of the Inouye balloon will be 28, and we have to take a 24 size balloon and gradually re-expanding to 28 if needed. So we take the syringe, we fill with dye, and we measure the balloon size at the level of full inflation. And in the PTMC procedure, this broken bone needle, the distal curve corresponds to the direction of the arrow at the hub, and this is very important in the PTMC procedure. Which direction the arrow at the hub will remain. The broken bone needle is passed through the Mullen sheath, and after placing the pigtail catheter in the non-coronary sinus, that means the lowermost sinus of the aortic root, we have to descend the broken bone needle from to the fossa ovalis region in AP or LAO view, and the pointer is taken to the 3 to 5 o'clock position, and it will make the distal sheath dilator perpendicular to the septum. At first, the broken bone needle along with Mullen sheath is dragged the entire system slowly from SBC to RA. So there is 2 jerks mainly from SBC to RA, and then second jerk from limbic ridge to fossa ovalis. And some people mentioned that there is some third jerk over the aortic root. And this is the schematic presentation of the jerks, first from SBC to RA, then reach to the fossa ovalis, and then over the root of the aorta. This is the fossa ovalis, you can see. So this is a PTMC procedure. The broken bone needle is passed through the Mullen sheath, and this is the descent of the broken bone needle, and there's 2 jerks you can see. There is the site of the septal puncture. We have to assess this by Inouye's method, and we actually follow the Hank's method. At the level of the root of the aorta where the pigtail catheter is placed, this is the upper limit of the tricuspid valve. We take a horizontal line here, and then we perpendicularly take a vertical line, and from this midpoint we take 1 vertebra or half vertebra below along the lower edge of the left atrium. So a half vertebra or 1 vertebra below this point is the septal puncture site in case of Hank's method. So this is the lower end of the pigtail catheter, and this is the horizontal line, this is the vertical line, and this is the crossing. And this is half vertebra below. This is the puncture site in case of Hank's method. So this is very important to achieve the success in case of PTMC. So the septal puncture site, if in case of size of LA, it varies. That means the broken bone needle orientation is 3 to 6 o'clock. That means if the LA size is 40, the needle will be 4 to 5 o'clock. If LA size is more than 60, the needle will be at the level of 6 o'clock. So this is the septogram, and this is the in the lateral view, the position of the broken bone needle is to the transseptal puncture, and puncture is finally done in the AP view. As you can see, the septal puncture is being done by the broken bone needle, and the needle is entered into the LA. If a suitable puncture is done, then we can do the LA-graphy, and the LA is being visualized. Then LA pressure is recorded, and we will do the broken bone drill and push the spring wire into the LA. Then there is septal dilatation is being done. Then the spring wire is kept in the LA, and Mullen sheet is withdrawn. Then we take the Inui balloon over the spring wire. Then we have to enter the LV by taking a shaper. This is called LV entry stylet or shaper. With the help of the shaper, we have to enter the Inui balloon into the LV. But sometimes LV entry is very difficult, and we have to take some modified approaches. After entering to the LV, the distal part of the balloon is first inflated, then the proximal part, and after full inflation, the mid ridge is the waist of the balloon is not visible. This is the Inuit technique of final phase. So after the immediately after PTMC, we have to monitor the hemodynamics and the LA pressure also. The accuracy of Doppler measurement during PTMC is low, so we have to look for the LA pressure, and if the we have to look for the planimetry, that means mitral area, whether it is increased more than 2 times of the baseline value or not. So this is the criteria for ending and PTMC. Valve area should be more than 1 centimeter square per meter square body surface area, or we can say it more than 2 times of the baseline value. And if complete commissural opening in at least one commissure, we have to end the PTMC. And if appearance of MR 1 plus, then we have to stop the PTMC. The criteria for successful PTMC are echocardiography valve area more than 1 centimeter square per meter square, and there is a speed of 1 or more commissures, and decrease of LA pressure by 50%. This is very important. If LA pressure is decreased more than 50%, then it is a criteria for successful PTMC. And decrease in length of the diastolic MR, diastolic murmur, and decrease in gradient by Doppler, and pressure shoot up sign. That means the aortic pressure rises after PTMC. And I will share some special cases done in our hospital NICBD by our team. This lady presented with shortness of breath on exertion for last 3 months, and he had history of rheumatic fever in childhood. As we know that the rheumatic MS is more common in our country, and she has severe MS with valve area less 1.9 centimeters square with moderate pulmonary hypertension, suitable for PTMC. So we did her PTMC, and valve area improved to 1.9 centimeters square. When you can see the splitted commissures. So this is successful PTMC. But her complaints not relieved after PTMC. After 2 months, she presented with shortness of breath and chest discomfort on minimal activity. So we planned her CAG, and we got this young lady has osteal left main disease along with severe MS she had. So we planned for the stenting of the osteal left main, and we funneled the stent balloon, and this is the final outcome after left main disease. So this lady has severe MS along with osteal left main disease. Next case, a 32 years old lady, normotensive, non-diabetic, mother of 2 children. Mother of 2 children, and she has shortness of breath, NIH class 2, and hemodynamic stable. She has loud S1, but a splitted second heart sound, and it's wide and fixed. And there is also mid-diastolic murmur. So we did her echo, and we found that there is evidence of MS along with a echo dropout in the interactive septum.
Tamal, I lost you. Tamal, acho? My network.
I think probably he froze.
Yeah, I think so.
This case is done by our team. I can continue before Tamal appeared. This is a case of Gutenberg syndrome. So moderate mitral stenosis with ASD second down, and there is a moderate pulmonary hypertension also.
So one thing that's, if you don't mind, I just ask a quick question about one thing on the mitral valve or mitral stenosis assessment. So sometimes we see that kichu patient symptomatic, but it's not really severe gradient, and then we do exercise and mitral stenosis assessment. Do we do that in Bangladesh?
Actually, we
exercise-induced increase in stenosis or gradient severity.
We routinely not do in our center, but sometimes we do. After exercise, there is an increase in pulmonary pressure. If there is symptomatic increase, significant increase of pulmonary pressure, then we proceed for procedure. But we actually do the symptomatic patient or asymptomatic, but there is severe mitral stenosis. These patients are most likely, and many of the patients, I have experience of 24 pregnant patient women to do the mitral stenosis, mitral PTMC in mitral stenosis, second trimester of pregnancy, and 2 of them are twin pregnancy, and 2 of the baby come with the mother come with these kids. One is 6 years old, twin. So these are the sometimes very complicated. One case I can remember that a pregnant lady with a severe mitral stenosis.
Can you hear me, Master?
Yeah, yes, Tamal is.
Yeah, Tamal. Sorry, we lost you.
We live in Bangladesh. We have schedule load shedding here. Crossing the load shedding.
Yeah, this is much better than not knowing when it's going to happen.
Yes.
And luckily, I got the generator on because I couldn't be able to present in my mobile because the slides wouldn't play. So I'm trying to.
I'm continuing your slide. That patient was Gutenberg syndrome. Then continue you. You continue.
I can start again.
So you start. I can describe. So it was a challenge for me that the pulmonary pressure is 52 or 56 millimeter of mercury, whether it is due to ASD or whether it is due to mitral stenosis. So we planned this case to do the mitral PTMC first, doing the mitral commissary tubing, and after 2 to 3 weeks, the pulmonary pressure reduced to 32. So this is surely the pulmonary hypertension is secondary due to mitral stenosis. So after 2 or 3 weeks, we do the ASD device closure of the.
Can you allow me to share the screen again? I'm not allowed to share the screen.
Let me see. It's Uma, তুমি কি পারবে ওকে একটু co-host করতে আবার, please? Uma or Shapnil? Uma or Shapnil, can you please make Tamal again the co-host so he can share? So while they're trying, we'll just continue a little bit of discussion. So Momin bhai, একটা জিনিস আমার question, আসলে আমরা তো এখানে এরকম কেস পাই না। আপনারা যে পরিমাণ mitral stenosis বা rheumatic mitral valve stenosis এর কেস পান, আমাদের এখানে তো আসলে মানে পাওয়াই যায় না। It is very impossible to find cases like that. So আমাদের case volume for mitral stenosis is very, very, very low. কোনো সন্দেহ নাই। আপনাদের ওখানের এক্সপেরিয়েন্স কিরকম, যে how long does this last? Is like, did you have to do repeated valvuloplasty on same patients?
Yes,
what's the sort of statistics there?
Yes, repeated valvuloplasty is done. Many of us doing repeated cases if it is suitable. all these, that have suitable anatomy, we can repeat. I have experience of a third time, PTMC of a patient of third time. So the patient is doing well. But usually it lasts 7, 8, 10 years very without any symptoms. But after 7 to 8 years, many of the patients come with symptoms, and many are asymptomatic for a prolonged period of time. So it is very utmost important is that commissure to one commissure is splitted or not. It is very important before doing, and gradual increase of balloon pressure is very important during the procedure. So if we do it meticulously from the very beginning, the outcome is very good, almost equivalent to valve surgery.
And you do that assessment of whether the commissurotomy is done or not at the time of the procedure by echo?
Yeah, yes, it is readily done.
Okay. Okay.
I'm still not allowed to share the screen.
Let me call the.
I'll just make a small comment, if that's okay, because the patient group that we see in UK, and I agree, Mushrif, I would say that in USA, the mitral stenosis patients are basically because of MAC, mitral annular calcifications, causing degenerative mitral stenosis in older patients, which are the nightmare cases in mitral surgery. That's the only reason I don't like mitral surgery myself, and that's why I went for aortic. And I think these patients, the problem is that the leaflets are the last one to get damaged, and it's all the annulus is very calcified. So the approach of PTMC or any valvuloplasty does not actually apply for this. On the other hand, the mitral stenosis that is normally presented in Bangladesh, I mean, when I got trained there and I saw those cases, the ideal treatment, and this is an absolute recommendation, that you have to do percutaneous option. If it is not possible, then only you think about surgery. Surgery is never the plan A. So I think what you guys are doing is an excellent job here, and definitely the outcomes are really, really good. The only problem probably you might see if you do multiple occasions, that these patients end up having MR, and then it becomes a mixed mitral valve disease, and then you end up doing a mitral replacement surgery, I think.
Yes, sometimes it happens. Sometimes emergency mitral valve replacement may need it. Few one or two cases, but most of the cases we can done safely. And so it is the expertise. How many cases you have done, then the complication is that.
Absolutely, absolutely.
Normally you can
yes. Now I can possibly, yes. So I was telling the scenario of that patient, Lutyens-Becker syndrome. Ashraf, am I visible?
No, your screen is not visible.
Not yet. Not yet.
So I agree. I agree with the comments just made. I have a question for you. You said that about the TAVR in NICVD. You started doing them. Are you keeping track of the clinical outcomes of these patients? Because I think it is important to know, if the cheaper valve is actually working and they're comparable, at least in the real world, with the other valves. I think it would be important for our patients as well as for your own database. Is there any way to keep track of that in Bangladesh?
Yes, Dr. Pradeep Kumar Karmakar and his team, as a member of a team, we are doing, we are keeping the data, but mainly it is kept by Dr. Pradeep and his colleagues. So I am an auxiliary member of that team. So they are doing fine. 2 patients I know that they are doing fine. But the Merrill company of India, they have their own data in Indian population. They are doing fine. Probably they are publishing their 5 years data. So that will be very important and encouraging for us.
There is also a Chinese company that I forgot the name. I think they also have self-expanding TAVR valve, right? But that's not I don't know what's the costing for that, or whether this is really good at all in comparison to Indian. Was there any experience like that?
No. We one first ever was done from Medtronic valve and in a private hospital, but in our institute in ICBT all the valves are made.
So should I proceed, Master Bhai?
Yeah, please proceed.
So I was about to show the case of Lutembecker syndrome. This is the valve area of that lady. She's 30 years old. So she has severe MS, you can see, and the PSP was 52 millimeter mercury. So this by pulmonary hypertension can be contributed by MS and also by ASD. And this is a transmissible echo of this lady showing there is ASD. So this is a case of Lutembecker syndrome. So we proceeded for first PTMC of that lady, and balloon size was 25 millimeter. PTMC was successful. You can see the valve area improved to 2.17 centimeters square, and commissures are straight. And after post PTMC transference echo shows the mean gradient is 4 and PSP is 35. And then after 2 weeks, after stabilizing her, we proceeded for the ASD device for her. So we ensured complete structural solution for the lady of a Lutembecker syndrome. And she comes to us for follow-up. And after the ASD device, this is her echo at the discharge time. She has the ASD device in situ, and this is the opening of the mitral valve is quite okay. So she has mild MS, you can see, and ASD device in situ with no residual shunt across the entire receptor. And her PSP got down to 21, and valve area at discharge was 2.51 centimeters square. Now, next case, a 25 years old normotensive non-diabetic housewife presented with progressively increasing NOS class 2 to class 4 for 3 months and orthopnea and swelling of legs for last 7 days. She was pregnant for 4 months and was quite asymptomatic in the pre-pregnancy stage, and she didn't know her diagnosis. We diagnosed her at NICBD that she is having severe MS, and she has mean gradient of 23.6, quite high, with severe TR, and you can see very low valve area. It is only 0.46. You can barely see the valve opening. And she is a pregnant lady of 4 months and approaching her second trimester. So this 18 weeks pregnant lady, we first treated her conservatively and stabilized her, and then went for PTMC. And lead shields were used at the back of the lady at the OT table to protect the abdomen and pelvis during the procedure, limiting the fetal radiation exposure. And we tried to keep the fluoroscopy time as much minimum as possible. And PTMC was successful. And immediately after PTMC, valve area rose from 0.46 to 1.25, and after 1.5 months, 1.43. And she completed her pregnancy successfully, and she has a baby now, which is more than, say, 7 years old now. So MS in pregnancy, valvular heart disease complicate 0.5 to 1.5% of all pregnancies. Mitral stenosis is the most common. The symptoms are poorly tolerated, especially beyond second trimester. This hemodynamic change might result in an increase in transmitral gradient and left atrial pressure, which may lead to acute flash pulmonary edema and may lead to frank heart failure. That lady was quite asymptomatic before the pregnancy, but at the time of pregnancy, she suddenly felt there is increased breathlessness even at rest, and she came to NICBD, and we diagnosed her MS, which she didn't know. And this was a valuable pregnancy. We ensured PTMC at the second trimester, and she is well with her baby. The next case, a 32 years old lady with shortness of breath for last 6 months with history of rheumatic fever. And this is the valve area. You can see there is MS. And here you can see the LA and RV is in the right side. So this patient actually has dextrocardia. So we did a first case of dextrocardia patient approaching for PTMC. The first test of PTMC in dextrocardia patients was done in our center. So we took the arterial and venous sheet in the left side of the femoral side, and we took the broken bone needle. Then we take the descent from supine vena cava to RA to fossa ovalis. And in case of levocardia, we keep the broken bone needle at 3 to 6 o'clock, as I mentioned. But in case of dextrocardia, we have to keep it 7 to 9 o'clock position. Here it is kept in the 7 o'clock position. The direction of the broken bone needle is very important to achieve successful puncture of the septum. And in the fluoro, we took the mirror reversal of the fluoro image so that we can puncture the septum in our usual view, so that we can appropriately puncture the septum with the Hans method. So here the puncture is being done, and the broken bone needle is in the LA. You can see. After that, with the dextrocardia patient, you can see the LA is visualized after the puncture, septal puncture, and the finger is in the LA. And we took the innovative balloon over this finger, but we felt very difficulty to enter the LV. We tried several times, and with some modification, we took the Mullen sheet over the finger, and after trying several times, we could enter the LV with the finger. This was a difficult case to enter the LV, and finally we could end the procedure and completing the PTMC in a dextrocardia patient. This is the first case. And we searched the literature. There was about eight case reports of PTMC in dextrocardia patients over the world. The procedure is being completed. This is the reversal of the fluoro image. The PTMC was successful in dextrocardia patient, and there is commissural splitting is there. PTMC has many complications. So I can show some cases of us. Here you can see with the broken bone needle, the aortic root is inadvertently punctured, and you can see the coronaries here. We are very shocked here that what will happen to the patient. But we waited for about 15 minutes. Patient was hemodynamically stable. There was no pericardial evasion, and then we proceeded further with the procedure of PTMC, and we completed the procedure safely. And this is case 2. This patient has severe MS. You can see the valve area is 0.70 centimeters square. We felt very difficulty to enter the LV, and so we modified the we took some modification. We took the J-shaped wire, and we extend the J-shaped wire and introduce the innovative balloon over the spring wire and try to enter into the LV. And we failed in this approach. Then we took another method. We removed the J-shape, the spring wire, and we removed the innovative balloon, and we took the Mullen sheet over the spring wire and try to enter the LV with the help of the Mullen sheet with the spring wire. But we failed again. Then we again took the J-tipped wire, and by modifying its tip, we were able to enter to the LV. But when we enter the LV, you can see the innovative balloon is hitting the LV wall, and we completed the procedure later. The innovative balloon is being inflated. But after the procedure is just ended, patient developed hypotension, and patient went into arrest, cardiac arrest over the table, and the whole team jumped into the CPR. Here you can see the CPR is being started, and we did the bedside echo, and we found that there is pericardial evasion, there is pericardial tamponade. So we started the autotransmission very quickly, and patient CPR is being continued. At that time, we are very much puzzled, but the whole team contributed for the CPR. As you can see, someone is giving the ambo bag, and someone is doing the autotransfusion. And after doing about 40 minutes of transmission, we could save the patients, and we shipped the patient to the CCU, and we kept the patient to CCU after for 2 days. And you can see the before discharge echo, it is valve area is improved 1.3 centimeters square. And we could save the patient by doing the auto transmission. We did the 3D echo of the patient to find out what might be the cause of this pericardial tamponade. You can see the valve area is improved, and 3D stain echo shows there is some infralateral wall positive stain indicating possible site of injury. So during the difficulty we faced to enter the LV, the inner balloon might have hit the LV wall and doing some perforation which must be auto sealed by the auto transmission we did in the cath lab. So we identified the possible cause that there was pericardial tamponade. We did the CPR, and we continued the auto transmission that saved the patient's life after a successful PTMC. So these are the complications of PTMC. As you can see, the pericardial tamponade is 0.2 to 1.4% of cases patient might have pericardial tamponade, and there are some other complications. So PTMC patients has in-hospital mortality ranging from 0 to 3%. The main cause of death are massive hemopericardium and poor condition of the patient. If hemopericardium occurs, it is related to the transseptal puncture or left ventricular perforation by the guide wires or the balloons. It occurs in less experienced operators. Unfavorable patient characteristics such as severe LA enlargement or severe thoracic deformity, and incidence varies from 0.5 to 12%. When to suspect hemopericardium, if the patient is a hypertension in the table, and it should be confirmed by echo and increase in cardiac size in the fluoro, and we have to proceed for immediate pericardial synthesis as we did in that case under echo guidance and reversal of anticoagulant. And most of the time, pericardial synthesis is sufficient, and PTMC can be reattempted at a later time. And if we fail everything, then surgery is the last option. Sometimes patients develop severe MR in case of PTMC cases. If we don't select the patient properly by the previous echo evaluation, these things may happen. Severe MR is due to mostly non-commissural leaflet tearing, and may also be due to excessive commissural splitting or early rupture of the papillary muscle. And the frequency of severe MR ranges from 2% to 19%. This is the autopsy view of this is surgical view of a patient of MR, severe MR. You can see the anti-liquid is teared by the PTMC procedure, and this is the MR jet. And we have our publications of PTMC. We did the modified approach to enter the left ventricle in our experience, and we had the experience of 80 cases. When we faced difficulty into left ventricle, we took 2 over-the-wire techniques, and we also look for some causes of difficulties of entering into left ventricle, and we found that the causes of difficulties are critical MS, giant LA, low septal puncture, thickened septum, and non-specified causes. So the modification we took in our difficult cases are the over-the-wire technique. That means we took the inner balloon over the spring wire and tried to enter the LV. And if this one failed, we took the Mullen sheet over the spring wire and tried to enter the LV. Another modification was the LA visualization. Usually LA-graphy is done in the conventional AP view. We did the LA-graphy in the RAO view, and in RAO view we can see the mitral valve orifice. So the LV entry is guided by the RAO view. So this is the AP view. This is the RAO view. In case of RAO view, the LV entry is a bit easier. So we the LA-graphy nowadays in the RAO view. This is another modification. So we published this in a journal, and you can see the long-term results for PTMC is quite satisfactory. The 10 years event-free survival rate is about 50% to 90%. So it is equivalent to surgical commissurotomy, as you can see. So my take-home message today: rheumatic MS is commonest in this part of the world. PTMC is an excellent method of intervention to relieve symptoms in severe MS with favorable anatomy, with long-term follow-up data is equivalent to surgical commissuration. Patient selection is crucial for a successful PTMC. Hemopericardium is not uncommon and may be detected even after successful PTMC. LV entry is a tricky part. Gentle manipulation and control application of force is mandatory. As PTMC is a blind procedure, it should be done cautiously to avoid life-threatening complications. Thank you. I think I've ended my presentation. Thank you.
Thank you, Tamal. Thank you so much for your really, really excellent presentation and this modified technique. And as I said, like we really do not do a lot of mitral stenosis cases because the case volume is একদমই ভালো না এখানে এবং আমার কাছে সবসময় মনে হয়েছে আমি আসলে খুব বেশি করিও নি বোধহয় হাতে গুনে বোধহয় 5টা কেস এখন পর্যন্ত করেছি এবং আমার কাছে সবসময় মনে হয়েছে যে this ineo balloon which is probably a very, very old equipment, and this equipment needs to be modified in some way. মানে এটাকে এলভি তে ডিরেক্ট করা এতই মুশকিল মনে হচ্ছে আমার কাছে এবং এটা differential inflation হয়, right? Like first a different part and then I pull it back, keep it in the mitral position and then inflate fully. Sometimes it just comes off, it slips off from the LV and it's very, very hard to go in. So এটা আমার কাছে একটা ছিল যে this equipment needs to be improved some way or other because it's challenging. I can see Lopa Appa. Lopa Appa is a general and imaging cardiologist. Lopa Appa, do you have any comments on of our topic today? Or Ashikul Islam Bhai?
No, I agree with you. Can you hear me?
Yes.
Yes.
I agree with you. Our volume is very low. It's in my practice is probably a couple of cases, 2 or 3 cases a year. So it's very comforting to keep your skill set to keep doing it. But of course, we still get some of these patients from other practices too, and we have immigrant population that are the main source of mitral stenosis in US in my practice. Yes, I think the comfort of the procedure increases if you do a good volume every year. It's very difficult to maintain that. But I'm really impressed with what you have presented today. I think the difficult cases were really quite amazing. Especially what impressed me was the dextrocardia case, and the other one is the LV perforation, which was amazing safe. I really still I'm in awe that patient actually survived even after the direct balloon injury to the LV valve. One good thing about these patients they are relatively young, and their reserve is much better than elderly patients with degenerative mitral valve disease. And I think particularly that case, what was shown, the hemopericardium patient survived eventually. I think the life-saving procedure was the mitral valvuloplasty that was still done in that case. That probably saved that patient's life. Yeah, so congratulations for extremely hard work and commendable work that you are doing there with all the other resource issues that you encounter, of course. So really, congratulations for that.
Thank you, Ashikul Islam Bhai. Lopa Appa, আপনি বোধহয় more mitral stenosis case পান just because of immigrant population in New York, right?
Thank you, Mashrafi. I'm unfortunate that today I'm on call and I'm in and out with the lecture, so I missed most of it, part of it. And initially it was really, really interesting for me because it was related with the echocardiogram and the imaging part. Yeah, we get a lot of, as New York City is a high rich with immigrant population, so we kind of get quite a few mitral stenosis almost every week, and other valvular disease as well. So it was an excellent discussion, actually. The intervention part, even though I'm not an interventional cardiologist or cardiac surgeon, but I really learned a lot about that. Especially, that was amazing, actually, the dextrocardia with valvuloplasty case. Yeah, I have to admit, I never knew about that mirror image can be done with that fluoro, and this is the way to do it. Okay, thank you for the excellent presentation. My comment, actually, I can talk like we do Wilkins score a lot to decide about the valvuloplasty and whether patient go for the surgery. So Wilkins score is a very big factor. So I'm not, maybe I missed that part to discuss the Wilkins score here in this lecture.
Yeah, he presented that. Tomal presented Wilkins score.
Okay, I missed that actually. So after the Wilkins score, we decide, and especially mitral stenosis, actually patient medically get managed a lot. So to send the patient for the valvuloplasty, even for the surgery, we are very resistant about that. We try to manage medically first, especially beta block, controlling diuresis and the controlling blood pressure. So patient goes for the mitral stenosis surgery, usually patient whenever very symptomatic, even after all the medical management. Yeah, mitral regurgitation patient goes before the symptom. That's how is actually the guideline, ECC guideline also says, before even getting the symptom, mitral regurgitation patient should get the repair or the surgery, replacement of the valve. Because mitral regurgitation is a volume overload and give you LV dysfunction. So we kind of follow up every year or 6 month echocardiogram in systolic volume of the LV, and if it is more than less than 60% of the ejection fraction or more than 40 millimeter of LV systolic dimension, we send the patient, or if patient develop atrial fibrillation or pulmonary hypertension. So before getting symptom, we send the mitral regurgitation patient for repair. But mitral stenosis, actually, even after symptom, we try to manage and then send the patient. And I think that's how the ACC guideline also mentioned. So that's, yeah, we manage medically as well.
Thank you so much. For the sake of time, I will just ask Taufik Bhai and Momen Bhai for some comments and closings.
Thank you very much. Actually, it's just past midnight, so maybe I'll not lengthen the session more. It was a beautiful, elaborate lecture from Ashrafur Rahman. I really liked it. Though we do mitral cases a lot, but I think it's the most difficult intervention to perform because you're just that much bit away from a complication every time you make a septal puncture. So I feel it that way. Thank you very much for inviting me. Thank you all.
Thank you, Mashrafi, for inviting me. This is a very excellent talk. I learned many things, especially for mitral clip, and I wish your collaboration and help when that we can start a mitral clip program in our country. So this is
100%.
This is not an easy job, but assessment, transesophageal echo, these are especially the transesophageal echo assessment is very important, and our procedural transesophageal guidance is it mandatory? Yes.
It is. It is.
Yeah.
So this is all thing we have to learn and the scallops of mitral valve. It is not easy to which scallops we are seeing in which view. This is not an easy thing. So if with collaboration of an experienced team, we can run a mitral clip program, but a bit difficult program because of cost, financial ability of our patients and other things. But few of our patients are able to do this. So if we learn and we use more and more, the price will be reduced and the alternatives will be available like mitral clip. So this is a very fruitful thing, I think, and thank you very much for your nice program and inviting me in this program.
Thank you, Momin Bhai. And that was one of the main purpose for this PHS program today, to get connected with Dr. Islam and all of you from Bangladesh, just in case if you guys need any infrastructural help or building up programs from the basics.
We can help a lot, even
as
virtually.
best as we can, right? So thank you for everyone for joining. And with that, I would like to close today. And thank you to my speakers. One of my friends just pop up here, Shakil. Thank you.
না আমি শুনছিলাম। তমাল একটা প্রশ্ন আমার ছিল যে as efficient patient selection for PTMC is the cornerstone of success. সেই ক্ষেত্রে আমার যেহেতু থিসিস এবং সাবসিকুয়েন্ট অনেকগুলো কাজ ছিল 3D mitral stenosis 3D on mitral stenosis, আমরা 3D evaluation করি কিনা? Because a commissural calcification can well visualized by 3D rather than 2D. Real-time 3D echo-ta আমরা কিছু কেসে করি কিনা?
আমরা 3D routinely করি না. We don't do the 3D cases routinely, but we can do when there is some suspicion about the commissural calcification. We should proceed for 3D echo evaluation. Yes.
3D evaluation to detect commissural calcification can avoid severe MRI.
Sizing is also better evaluated by 3D.
Yes, sir.
Thank you. I know it's quite late at Bangladesh, and সবাইকে জাগিয়ে রাখার জন্য আমি আসলে দুঃখিত. But thank you to my speakers, Ashikul Islam Bhai and my very close friend Amal. Keep in touch if we can come of any help in any possible way. And I learned a lot from you today. Thank you so much. Good night.
Thank you very much. Bye.
মাসে ভাই ভালো থাকেন।
হ্যাঁ যোগাযোগ রেখো। হ্যাঁ
ঠিক আছে থ্যাংক ইউ।
ওকে ভাই। শাকিল,
হ্যাঁ
খুদা হাফেজ।
থ্যাংক ইউ।